Well, welcome everyone to our center research rounds. And so just before we begin today, I just like us to take a moment to thoughtfully consider that we are having this presentation on the um, unceded territory of the Mi'kmaq. We are all treaty people, and I think that most of us have benefited and are really need to work together and thoughtfully think about the best way for truth and reconciliation. So, again, we are here today on beyond ceded territory of the Mi'kmaq. And I am really thrilled to have two amazing talks today. The first is going to be on healthcare and climate change, the need for planetary health and sustainable health systems by Gillian Ritcey and Jessica Nowlan. And when we start, I'll have them fully introduce themselves to you. And the second presentation will be on role development and utilization of master's prepared Almukhaini nurses working in clinical settings, a multiple case study. And that's by Salma Almukhaini, a PhD candidate at the School of Nursing. So without further ado, Gillian and Jessica, would you like to start?
I'll just share my screen. Thank you so much for having us today. My name's Gillian Ritcey. I am the Managing Director of the Healthy Populations Institute at DAL, and I'm thrilled to be here. I'm going to start our talk by really focusing on presenting a case for change. And so understanding that healthcare is in a climate crisis, and that we could take a planetary health and sustainability approach to make some change. For those of you who don't know the Healthy Populations Institute, we're a cross-faculty institute here at Dalhousie with founding faculties of medicine, dentistry, and health. And we explore the determinants of health and well-being in our populations. So we take an upstream approach to understanding how ecological, structural, and social determinants impact our ability to reach maximum health potential for everyone. And so our talk today is really focused on the ecological determinants, so the foundational determinant. And this is based on our understanding that all human health exists within an ecological context, and that threats to our ecosystem are therefore threats to our health. So I'm sure you've heard the term planetary health. It's very much, a buzzword right now. And when you think about planetary health in its simplest form, is that a healthy planet is a requirement to have healthy people. And so that's kind of the foundation of this work. According to the Intergovernmental Panel on Climate Change, so that's a UN group, climate change alone has been identified as the biggest global health threat of the 21st century. So how is this showing up? So changes to our ecosystem is leading to climate change. And I think that this is an amazing graphic that was recently published by Dr. Courtney Howard and Dr. Andrea McNeil, both leading Canadian physicians in this field. And with this graphic, we see that the impact that climate change is having on health is happening right now. We see that in terms of health-related illnesses. We see an increase of vector-borne diseases. I believe that Lyme disease in Nova Scotia is at an all-time high. We're seeing increases in asthma, COPD, and other forms of health changes. We are also seeing that climate change is having an impact on our health systems and our ability to provide high quality care for all. So examples of this include the increased number of patients with disease patterns brought on by environmental factors. This is causing disruption. We're seeing disruptions in the supply chain due to extreme weather events. And so there's a lot of change happening, and we're feeling it from both a health perspective and from a healthcare perspective. So if climate change is the biggest threat to human health, then health systems and healthcare professionals must take action. And there's kind of two ways that the health system can respond. And the first is adaptation. So this is actually building resilience into our health systems to respond to the effects of climate change. So this means that we have to adapt our infrastructure and our clinical pathways to a changing climate. And this means things like confronting flooding, confronting increasing intense wildfires and deadly heat waves that we're already seeing beginning to devastate parts of our country. So really adaptation is about preparation. We know that things are changing. We know health patterns are changing, that healthcare pathways need to respond to account for these new health risks. In November 2022, the federal government released its first ever unified plan to adapt to a changing climate. So this is Canada's National Adaptation Strategy. And the strategy came with 1.6 billion in new federal funding meant to help maintain and climate-proof public infrastructure, reduce the impacts of climate-driven disaster, and restore natural ecosystems. Within the strategy, they do address environmental sustainability, but not directly related to health systems. It's kind of framed as something that all sectors need to be doing. But along with the National Adaptation Strategy, they co-released an action plan. And it's actually within that action plan that there are attention to health systems. And so specifically, they say that healthcare is a highly intensive sector contributing to climate change, and that health authorities have to be involved in reducing those impacts. And they announced an expanded Health Adapt program. So at this point, it seems like there's going to be funding available for health authorities to do climate change adaptation initiatives, but we're still waiting to see what that actually looks like in practice, how much money there is, how health authorities would apply. But it's just to say that Canada has released some high-level policies around the adaptation angle. The second way that health systems and health professionals can respond is through mitigation, and that's transitioning to low-carbon health systems. So the real paradox with this work is that the healthcare sector is a significant contributor to climate change. Healthcare is not only affected by climate change, it is a major part of the problem. So the Lancet has an ongoing special issue on planetary health. And in 2019, they embarked on establishing the first ever estimate of healthcare's global climate footprint. And the report found that healthcare's footprint is equivalent to 5.2% of overall net greenhouse gas emissions, and that if the healthcare sector was a country, it would be the 5th highest emitter in the world. So how is Canada doing? We're not doing great. So in the same Lancet publication in 2019, Watt et al. Released a study that found on a per capita basis, Canada's healthcare sector ranked third globally in terms of the highest greenhouse gas emissions. So what's Canada doing in the mitigation space? At the UN Climate Change Conference in 2021, the COP26, Canada signed on to the health program. So that's a formal global initiative on resilient low carbon health systems. So they have signed on to essentially decarbonize our healthcare system. But at this point, there have not been any formal commitments to targets or timelines. In the same year, the Canadian government released the Canadian Net Zero Emissions Accountability Act, which aims to get to net zero carbon emissions in every sector by 2050. And so this would include healthcare. Canada also signed on to the World Health Organization Alliance for Transformative Action on Climate and Health. It's called the ATTACH program. And ATTACH is working to build climate resilient and sustainable health systems by using the collective energy of the WHO member states and other stakeholders to drive this agenda forward. So there's 4 thematic groups working with the ATTACH program, and Canada has representation on each. And so, based on these notions of adaptation and mitigation, we see that there's a need for health systems to take a planetary health and sustainable health systems approach. So first, we must understand the relationship between climate change, its impact on health, and its impact on health systems. And that's taking a planetary health approach. We need to know how the changing natural ecosystems are going to affect human health and also for our ability within the healthcare sector to offer high quality care. And so to do so, we need to make adaptation plans and be proactive in our ability to build resilience into these coming changes. The second pillar is the relationship between climate action and the healthcare sector. So we know that healthcare is part of the problem. And despite its aim of protecting health and doing no harm, healthcare systems around the world are contributing to climate change. So in order to minimize the negative effect that climate change is having on health, the healthcare sector has to be involved. And we really need to start this transition to low carbon, climate resilient, sustainable health systems. And those are systems that improve, maintain, or restore health while also minimizing the negative impacts on the environment. So I want to end this presentation by bringing your attention to how Dalhousie is contributing in this space. So the Healthy Populations Institute is part of Cascades, and Cascades is a national initiative named Creating a Sustainable Canadian Health System in a Climate Crisis. Cascades is a multi-year capacity building initiative aimed to address healthcare's role in climate change. And it's supported by Environment and Climate Change Canada, and it's really meant to catalyze change towards a sustainable, net zero, resilient health system. So HPI, the Healthy Populations Institute, representing Dalhousie, is one of 3 academic institutions really leading the way in this space in Canada. Cascades is led by the University of Toronto's Centre for Sustainable Health Systems. It's also in partnership with the Planetary Healthcare Lab at the University of British Columbia. And we're also partnered with a national NGO named the Canadian Coalition for Greener Healthcare. They've been in this space for about 20 years. So we're trying to put all of our collective energy together to develop education, resources, tools, and policy recommendations for how Canada can really begin to take action in this space. Given the audience here, I wanted to bring your attention to this resource. So for National Nursing Week in 2022, Cascades and the Canadian Association of Nurses for the Environment, named CANE, shared nurses' stories from across the country about how nurses are engaging in environmental sustainability and environmental justice within their roles in hospital, community, administration, education, research, or government. So there's about 20 stories on the Cascades website about how nurses across the country are really leading the charge and contributing to climate action in healthcare. And I encourage you to take a look for, inspired ideas and some background on how they got involved. So I'll end with this quote: the healthcare sector contributes significantly to climate change, which means if the sector does not introduce climate-friendly policies and practices, it paradoxically will continue to contribute directly and indirectly to negative health impacts through the emission of carbon dioxide and other greenhouse gases. To meet the growing demand of healthcare resources without furthering climate change, future health systems must be built on sustainable and low carbon systems and models. Thank you very much. I'm actually going to pass it over to my colleague, Jessica, to talk about one of the main pieces of work that Cascades has been doing across the country.
Thanks, Gillian. I just want to check that everybody can see my slides. Yes, and just the slides. Okay, yeah. Perfect. Great. So as Gillian mentioned, my name is Jessica. I'm the regional lead for Atlantic Canada with Cascades. And now that Gillian has sort of set the stage about the need for sustainable health systems and some of the work that Cascades does, I'm going to briefly go over one of the playbooks that we produced last year. So this is a quick overview of a pretty complex topic. So I'll just say, if you're interested, if anything piques your interest, there is a whole playbook about this on the Cascades website, and you can check that out for more detail. So this was produced by Cascades in partnership with Synergie Santé Environnement, who are based in Quebec, and they are a not-for-profit that has experience helping organizations understand their greenhouse gas emissions. And we had lots of people from across the country as part of our working group and reviewing as well. So Gillian made a really compelling case about why we need to act on this, and also mentions the Atlantic Countdown. So they've been kind of sounding the alarm on the health implications of climate change. Their most recent report in 2022 warned that climate change is affecting the health of people worldwide directly with increased exposure to extreme weather, and indirectly with the impacts on the physical, natural, and social systems on which health depends. And we talked a bit about the emissions attributable to health systems and healthcare globally. A study in Canada found that about 4.6% of greenhouse gas emissions in the country are attributable to health systems. So just to put some context of kind of where we're at here. So there's been a lot of growing interest and action on this. So just to reiterate, in November of 2021 at COP26, countries were asked to sign on to the World Health Program, which meant they were basically committing to develop climate resilient health systems and to develop low carbon sustainable health systems, and to commit to reaching net zero and to set a date for that, for being net zero in their health system emissions no later than 2050. Canada did sign on to that health program in 2021 and committed to developing climate resilient health systems and low carbon health systems, but no commitment to net zero or a target date for that. As part of this commitment, the countries are being asked to deliver a baseline assessment of their health system greenhouse gas emissions, including those that come from the supply chain. And so this commitment to deliver this assessment really brings into question, the idea of measurement and, how can health systems estimate their greenhouse gas emissions so that they can track reductions, progress towards reaching net zero? Are they meeting the targets they've set out for themselves? So at an organizational level, so at the level of a clinic or a hospital or even at a health authority level, there's different ways that greenhouse gas emissions can be thought about and reported on, different frameworks that are used. One that's used very commonly is the greenhouse gas protocol, and you may have seen this before or heard of the idea of the 3 scopes of emissions. So that's a way of kind of thinking about different sources of emissions and where they fall kind of within an organization's activities. So this graphic here breaks down some different sources of emissions by scope and has some healthcare examples in it. So direct emissions, or scope 1 emissions, are really things that are emissions that are from sources that are directly owned or controlled by an organization. So an example of this would be the emissions from the fuel that you combust in your furnace to heat a building. An example in healthcare would be release of anesthetic or other medical gases into the atmosphere. Indirect emissions are a consequence of the organization's activities, but they can't be directly controlled. So for example, if you look at scope 2, those are the emissions that are generated as a result of producing purchased electricity. The other scope is scope 3, which really encompasses everything else. So this encompasses things like commuting, all of the purchased goods and services, so that idea of the supply chain. These can be either upstream, so emissions that are happening before basically the organization takes control. And so this would be something like the emissions associated with transporting a purchased good from where it's manufactured to where it's going to be used, so say to a hospital. Downstream emissions are emissions that happen after the organization has control. So an interesting example here with healthcare relevance is the use of metered dose inhalers for the treatment of conditions like asthma. So metered dose inhalers actually use a greenhouse gas as the propellant. And so the prescription would be happening within a healthcare organization, but it's actually being used by the patient, in community in their home. And so those emissions are happening, we consider those to be downstream. So where are the sort of biggest sources of emissions in healthcare? In Canada, a lot of the focus of healthcare organizations so far has been on estimating their scope 1 and scope 2 emissions. So these are things related to buildings and to energy use, essentially. This is where you see things like building retrofits, trying to have energy efficiency programs, those types of things. However, in that same study I mentioned before that gave us the 4.6% of Canada's emissions coming from healthcare, they found that most of those emissions are not scope 1 emissions. Only about 1/10 of emissions are from scope 1. And the other 90% of emissions are indirect. They're from scope 2 and scope 3. And other large-scale studies in other countries have shown similar things. And so looking at an entire country's health system is a kind of a different methodology than considering, one hospital. So we can't necessarily say that it would be exactly the same in any given site. We see that most of the emissions at a system level, at a country level, are coming from those scope 3 emissions. And it does highlight the fact that we need to be thinking about and acting on emissions from as many sources as possible, and not only on buildings and energy related emissions. I just want to quickly highlight some work that's happening in England, because the NHS has put forward some really ambitious targets to reach net zero, and are kind of leading the way on this in a lot of ways. So they've identified a trajectory to be net zero by 2040 in what they're calling sort of their NHS carbon footprints. So that's all of their scope 1 emissions, all of their scope 2 emissions, and some scope 3 emissions that they have some ability to influence. So for example, they've put business travel in there, and you can see how policies mandating that people take a train instead of an airplane, could affect those emissions. And then by 2045, they've committed to being net zero for all other sources of emissions. So that includes all the things from their supply chain, pharmaceuticals, medical devices, commuting, and even the way that patients and visitors travel to their facilities. They're doing this, they have a centralized approach to collecting this data and doing this measurement. And actually in 2022, the Health and Care Act was revised to actually embed these net zero targets into legislation. So this means that all organizations in the NHS now have green plans that lay out how they're going to reduce their emissions in their local settings. And they also have someone on their board who's a net zero lead. So there's a really, a lot of really strong levers there to make this work happen. And then I'll just finish by briefly going over some of the things that might be required for healthcare organizations or even at a system level to engage in this type of work or expand on this type of work. There needs to be support, there needs to be human resource support and appropriate data systems. There needs to be engagement of senior leaders, of people from across the organization. For example, clinical engagement, looking at things like using different anesthetic gases during surgery, infection control engagement, looking at the pros and cons of reusable or disposable PPE, food services, can you change menus that are served in hospitals, etc. And also engagement with suppliers. Is there a way to build in greenhouse gas emissions considerations into things like RFPs, for example? And just a final note to say, it's also important to understand some of the strengths and limitations of doing this type of measurement, and to caution that organizations need to be aware that there are a range of environmental impacts that need to be considered. Greenhouse gas emissions are very, very important, but not the only thing. And so to avoid fixating on reducing emissions, at any cost and having potentially negative trade-offs where other environmental impacts are maybe being increased. So that's it from me. Thank you so much. As I said, there's a lot to go into on this topic. We did publish a playbook on it. If you're curious about any of this, please do reach out. My email's up there. And thanks so much for your time.
Oh, Gillian and Jessica, what an amazing talk, and so timely and relevant to all of us with respect to climate change. I think we have time for one or two really quick questions before we'll have Salma start. If there's anyone who would like to make a comment or ask a question. I'll just ask one. I thought it was really interesting about then of course, as a nurse, I thought it was very interesting about the stories, and just wondering if you could give maybe one or two quick examples of some of the things that they did. I think it's sometimes, it seems so daunting about where to start. So maybe just one or two examples would be great.
Yeah, let me, so, I mean, a lot of the work starts at kind of the micro levels. So the nurses would look around their care setting and see what they had a scope of influence over. And I know that in healthcare, one of the big kind of things that's really in your face is around waste. Like that's kind of something that really gets people going, and just how things are disposed of, and how that's done. So I know one of the nurses focused on like a waste management project for her ward, and actually ensuring that things were properly sorted and then taken out to the right places, and that not everything was just put in a bin and incinerated, which was happening. And I know there was also a focus on reusable PPEs. So not just kind of wearing one mask and throwing it out, but thinking about ways that a mask could be worn across like multiple events or for a certain number of hours. So it wasn't just like one and done. But there's also a lot of advocacy campaigns within those stories. And I think that if anyone on this call is interested, the Canadian Association of Nurses for the Environment does really excellent work. We've got representation on our advisory committee for Cascades from Kane. And they're trying to really understand from a nursing perspective, where's the biggest bang for our buck? How do we organize? How do we spread and scale some of these best practices? So I would really encourage you to become a member or think about what membership might look like for you, as you know, that you'd probably get a lot richer conversation from people that understand kind of, you know, your background and your scope of practice.
Well, thank you again, both of you. I think basically to me, the take home is this is such a tremendous problem, and it really affects all of us at every element of our lives and families, and that each of us really need to, regardless of your discipline, it's not just the environmental folks, it's really the healthcare folks who need to step up and think about how we can reduce. And I think the fact that we were third, it's one of those things, it's not good to be high in the list. So that was pretty telling about the Canadian healthcare system. So thank you very much for taking the time to really share with us today your tremendous work and raise awareness.
Thank you so much. Thanks for having us. Thank you.
Great. And Salma, we'll move on to you. If you'd like to talk with us and share, I think you can share your screen. Perfect.
Can you see my screen now or no?
Not yet. No, not yet.
Just a minute.
Are you on a dual screen? Is it on the other screen? Other side? Oh, there you go. Great. And so just start you're in just notes. So just take go into presenter mode, I think, Salma, and you'll be all set. Perfect. It looks great.
So hi everyone. Yeah, hi everyone. I am Salma Almukhaini. I'm a PhD candidate from School of Nursing, and Dr. Ruth Martin Meissner and Dr. Laurie Weeks are my supervisor. I am happy to be here today to present part of my PhD research, which focuses on exploring role development and utilization of master's prepared Omani nurses working in a clinical setting in Oman governmental healthcare system. And I utilized a multiple case study as a research design. So I am from Oman, and this is a picture from my beautiful country. Oman is a small country in the Middle East. So the number of graduate level nursing education has dramatically increased worldwide, leading to more masters prepared nurses. And the focus of these masters of nursing, graduate level masters program has shifted from preparing nurses to be nurse educators and administrators to prepare them to be more focused in clinical roles like advanced practice nursing and specialized nursing practice. And this shifts had occurred as a response of change or increase in the healthcare demand because of increased patient complexity, the desire to increase access to care, cost containment, and also increased use of technology. And the roles of masters prepared nurses vary worldwide, vary by country, but some of the most common roles for these nurses are advanced practice roles like nurse practice. And nurses also work as nurse managers, educators, and researchers. In Oman, the number of masters prepared Omani nurses has increased recently after the establishment of the first Masters of Nursing program in the country in 2016. And according to personal communication, because still we don't have a database for nurses in Oman, there are approximately 100 Masters prepared Omani nurse work at Ministry of Health and 30 Masters prepared Omani nurse work at the University Hospital. So Ministry of Health and the University Hospital are the two main healthcare organizations, governmental healthcare organizations in Oman. Other governmental healthcare organizations are those affiliated with military services, but we don't have any data about the number of Masters prepared Omani nurses working there. Advanced practice nursing roles, which is one of the common role of master's prepared nurses, are still evolving in Oman. The first nurse practitioner joined the service in 2016, and Oman is still in the process of regulating the nurse practitioner role. We have also clinical nurse specialists, but this role is not regulated and could be practiced by both master's prepared and non-master's prepared nurses. Oman developed a 5-year plan for health development, 2020 to 2025, and that plan aims to increase the quality of healthcare services and patient care through proper utilization of healthcare personnel, including nurses. So we don't know anything about the role of master's prepared nurses or how these nurses have been utilized. So this research came to fill the gap, but by exploring the role and utilization of master's prepared Omani nurses, especially those who are working in clinical settings. And I mean by utilization as the type of role these nurses practice in the healthcare organization, and whether this role align with their education preparation and meet the goal of the healthcare organizations. But today I will just present the findings related to 2 research questions, which are: how have master's prepared Omani nurses working in clinical setting in governmental healthcare system in Oman have been utilized, and how were their role developed? I have another 2 research questions. One is, what are the factors that have impacted the utilization of master's prepared Omani nurses, and what are the perceived impact of their practice in patient care and healthcare organizations? But today I will present those related to the role development and utilization. I use multiple case study as a methodology, and use qualitative interviews and document review. So usually we use case study to develop in-depth description and analysis of a phenomena of interest in the contemporary context. So the phenomena of interest is the role development and utilization, and I use 2 cases to explore that, which are the Ministry of Health. I selected one tertiary care hospital under the Ministry of Health and the University Hospital. And I selected these 2 because these are 2 main governmental healthcare organizations in Oman, but they are 2 separate organizations. Each one of them has its own physical and organizational structure and rules, financial resources, and rules and regulations related to nursing practice. So I conducted some structured individual interviews with master's prepared Omani nurses. So I include only Omani nurses with a master's degree, those work in clinical. I exclude non-Omani master's prepared nurses, and I exclude Omani master's prepared nurses who work on private or educational institute, because their experience and career pathway are different than Omani nurses working in clinical settings. So I conducted a total of 19 interviews from both cases. I also interviewed policymakers. I conducted 8 interviews with them, and co-workers, and I conducted a total of 8 from both cases. I collaborated with director of nursing from the 2 cases to recruit the nurses, to recruit the participant. So the director of nurses sent invitation email to nurses, co-workers, and policymakers. And unfortunately, we didn't get a good response because it seems people there are not actively using their email. So we sent the invitation email using WhatsApp application, because WhatsApp is very common in Oman, and that was a really effective way to recruit participants. I also reviewed official documents, mainly the job descriptions of some nurses' role and career pathway. For data analysis, we did 2 levels of analysis. First is the within case analysis. So the team, we analyze each case separate, and then we do the cross case analysis, where we identified the similarities and differences between the 2 cases. And I use hybrid thematic analysis. So in hybrid thematic analysis, we identified the code prior to data analysis from sources like from our research question, from PEPA and PEPA Plus frameworks, because these are 2 frameworks we use to conceptually guide our research, and also from the scoping review that the team conducted about advanced practice nursing role in Arab country. And then we also identified the code inductively from the data. I think this is the interesting part, the findings. We have a lot of findings. I'll try my best to highlight the key findings in each theme. So we identified 4 overarching theme, and they are drivers for more master's preparation in clinical settings, the journey after pursuing a master's education, master's prepared nurses' role, their development and scope of practice, perspectives about the current utilization of master's prepared Omani nurses. So this is the first theme, drivers for master's preparation in clinical settings. So this theme summarizes why nurses pursue the master's education, or why the organization sent nurses for a master's education. And in both cases, we identified a number of patient and organizational needs that could be met or addressed by having master's prepared Omani nurses. So policymakers in both cases highlighted that service expansion in specialties and the learning needs of nursing workforce has driven the need for masters with advanced degree who could support the management, the specialty service, and also could mentor and train other nurses. Also, policymaker highlighted that because nursing profession is new in Oman, we need more leaders. So one policymaker said, now, we are trying to qualify most of Omanis because still, if we talk about nursing history in Oman, it is very new. We will send Omanis for masters because we want them to be leaders. But for master's prepared nurses, the majority of them related their master's education to their personal and professional development. So the nurses said, we went for master's education because we want to increase our knowledge, our skills, to have like a senior post, to be recognized as a master's prepared, and also to have a morning shift. Some master's prepared Omani nurses also related their master's education to the international requirement of their role, such as clinical nurse specialists and nurse educators. So this clinical nurse specialist from case 2 said, when you compare yourself to others in other countries, you need at least a master's degree to practice as a clinical nurse specialist. This was one of the reasons why I went for a master's degree. And another need also for having a master's education is, as highlighted by policymaker, by the nurses, and also by the co-workers, is the need to increase the number of research and conduction and utilization in Oman, because in Oman we have a limited number of research conducted by nurses and also about nurses or about nursing in general. And also having master's prepared nurses was one of the accreditation requirement, and especially some co-workers and master's prepared nurses, they said having nurses with advanced degree could close the status gap with other healthcare provider, which will eventually raise or improve the image of nursing profession in Oman. The second theme is the journey after pursuing a master's education, and participants here explain what the nurses experienced after they completed the master's education and they joined the service. So according to them, actually the nurses expect that after they completed the master's education, they will have like a higher post as a leader, as a researcher, or they have like more expanded scope of practice. But unfortunately, when these nurses joined the service, some of them mentioned that nobody even sit and meet them. They just came back and they joined the service. The administrator asked them to go to the same area, try to identify their goals and come back to them. So there was like a mismatch of expectations between the nurses and the administrators. So as I said, administrators expect no change, expect them to come with their own objectives and outcome, while the nurses expect to have more advanced role, expect to have some changes in their role. The nurses mentioned that there was any discussion with them regarding these expectations before or after they completed their master's education, which make them frustrated and also confused. So a nurse educator from case 1 mentioned, when I came, they asked me to go back to bedside nursing until they get a plan. They said, you need to work as a bedside nurse for 3 months and give us a report and evaluation. I said, this is already over. I work at the bedside for more than 10 years, and I knew what's there. I thought at that time, because they didn't have a clear plan for me, they were confused about where to put this master's graduate. So after they completed their master education and joined the service, some nurses went back to their previous posts. Some nurses were used to fill any emerging gaps in the organization. And for those who went to their previous posts, they work actively and proactively to expand their practice and to use the skill and knowledge they have without having any input from their team or from nursing administration. Some nurses also report there was no change in their scope of practice, but now that they became more engaged in administrative role, like being more member of committees in the hospital and also engage more in research projects. A few nurses said many of them said after master's education, we become more knowledgeable, more skillful, and they become more assertive in accepting or rejecting responsibilities given to them. So one specialized nurse from case 1 said, for me as a specialized nurse, I didn't see any difference between holding a bachelor degree and holding a master's degree. I feel I am doing the same work. However, I am more confident in saying yes or no to any given responsibilities, more than when I was a BSN graduate. The third theme, I think this is the most condensed theme, masters prepared nurses' roles, their development and scope of practice. So this theme summarizes the most common roles practiced by masters prepared Omani nurses, and we identified 3 sub-themes: nurses in administrative and managerial roles, specialized clinical nurses, clinical nurse educators. So nurses in administrative and managerial roles. So this is the most common role for masters prepared Omani nurses. Many of them work in administrative, like a director of nursing, and managerial role like head of department, head of unit. And the role of these nurses are very clear. Their scope of practice are really identical, like everyone know their scope of practice. So a nurse manager confirmed, saying that as a nurse supervisor in the unit, my role is very identical, and there is consistency between how the nurses in administrative role describe their scope of practice and role activity and their job description. I think this is the interesting role as well. Specialized nurses, those are nurses who work under a specialty team like oncology, hematology, neurology, or cardiology. These nurses called specialized nurses in case 1, which is the Ministry of Health, and clinical nurse specialists in case 2. And the need to assess physicians who could save time and to provide care to more complex cases was the main driver of the need for specialized nurses. So one physician described the need for a clinical nurse specialist by saying that their role is to save a lot of time for physicians. Because physicians cannot do everything by themselves, they are helping them and they are providing a great services. Interestingly, the role of clinical nurse specialist vary by specialty, like clinical nurse specialist oncology working differently than clinical nurse specialists for cardiology or neurology, because physicians in each team play a vital role in determining the scope of practice of a clinical nurse specialist. And clinical nurse specialists and also specialized nurses in case 1 declared that they wrote their own job description. And when clinical nurse specialist role was first developed, there was no job description, and they usually do what their team asked them to do. Now there is a job description, but still they describe that job description as general and vague, and it is not specialty specific. And this is why there are variations between the role activity of clinical nurse specialists in the university hospital. Some of them, they can do advanced procedures, and like physician train them to do some advanced procedure that's usually done by physician. Some of them, they can order medication, they can run their own clinic, and some of them, they can do, like they are doing non-nursing job like translation, running outpatient clinic, call patient in outpatient clinic, call patient for appointment. So there are a lot of variations. And another specialized role that only practiced by master's prepared nurses in case 1 only is the research nurse role. And this role was developed because of the accreditation requirement. And then the main activity of this nurse is to help in conducting research and mentoring and, teaching nurses how to do research. I just want to include that the specialized nurses, they were specialized nurses before doing their master's education, and they continue to work as specialized nurses after they completed their master's education. So master education was not a requirement to work as specialized nurses. A clinical nurse educator, this is the third sub-theme, and it is also some nurses in both cases work as a clinical nurse educator, and it is this role considered relatively new, and it was developed to meet the need to supervise, train, and mentor the grooming the growing nursing workforce in both cases. So in case 1, the role is practiced by both masters and non-masters prepared nurses, and in case 2, which is the university hospital, the role was only practiced by masters prepared nurses. In both cases, nurse educators highlighted that the role was not well established, and they described their job description as vague and in most cases self-developed. And because of that, the nurse educators in both cases declared that there are a conflict of interest between their role and the role of a head nurse, because usually the head nurse are the one who choose nurses to go to courses and is the one who educating nurses in the world. So these head nurses feel that the nurse educator are taking some authority from them, so they don't accept them. So a nurse educator from case 1 described her experience. Before the clinical educator role, this was the role of nurse manager. She was the one telling I want to start this course, I want to do this project. So now pulling that authority from them, it's not easy. And to convince them that this is the role of nurse educator, it wasn't easy. So it's not easy for them to accept this. Notably, the nurse educator role in case 1 have more wider scope of practice than their counterpart in case 2. So, for example, nurse educator in the tertiary hospital and the ministry, they can do staff appraisal, they can select equipment, while in case 1, their scope of practice was restricted to mainly teaching staff. The last theme is the perception about the current utilization of master's prepared Omani nurses. So the participants share what they think about the current utilization. So the majority of them believe that still master's prepared Omani nurses are underutilized, mainly in research. And this is mainly related to the lack of time and the high workload for the nurses, and sometimes lack of personal interest. And few master's prepared nurses working as a nurse educator and manager highlight that they were underutilized in setting policy and protocols, as highlighted by this ward manager from case 2. For approximately 2 years, I don't have any involvement in research. I was not invited to participate in updating any policy. And I thought that they are not utilizing the master staff correctly. And sometimes you feel like you are already moved to the corner. Some specialized nurses in both cases indicate that they were underutilized because of their limited scope of practice. Like some of them, they cannot run their own clinic and they cannot order medication. And those who have been given the authority to order medication reported that they are well utilized. Interestingly, only from case 1, many master's prepared nurses in case 1 asserted that, in fact, they were overutilized because they held more than one role at a time, as summarized by this nurse this nurse. I am holding the training on behalf of nursing training in the whole hospital, and at the same time, I am working on performance improvement for the hospital, and I am a head nurse for the unit's name. Interestingly, only a handful number of master's prepared nurses reported being well utilized, and those were nurses who worked in administrative or leadership roles. So in discussion, as you can see, master's prepared Omani nurses are mainly utilized in management and education, and I think that's not surprising and it is also similar to how other master's prepared nurses in Arab country and some international nurses also mainly utilize in management and education. In fact, that considered a positive move because, as I said, Oman is nursing profession is still evolving in Oman. It's considered new. So having nurses and management to support the management and also to set rules and regulation to improve the nursing practice is needed in Oman. The current utilization of master's prepared Omani nurses in both cases has not yet been optimized, especially for those working in specialized nurses and nurse educator. And we said this is mainly related to the lack of role clarity and role ambiguity and fluid scope of practice. Although, as you said, many roles of master's prepared nurses have been developed in response to certain organizational demand, they were developed using top-down approach. That means they hired the nurse to work as a clinical nurse specialist without having a clear job description, without increase the awareness among the team what the clinical nurse specialist should do, without make sure that the nurse have the right qualification to work as a clinical nurse specialist. So this is why these nurses struggle or the role is not well established. And also the role shaped by the expectation of stakeholder like the nurse administrator or the expectation of physicians. And also because of this fluidity in the role, we noticed like a lot of inter-organization variations in the role of some nurses and also cross-organization variations. So the implication for the practice, policymakers and healthcare resource planners need to use systematic evidence-based need assessment to clearly identify patient organization and system-wide needs for master's prepared nurses. After identifying the needs, they have to determine how much in number and specialty they need from master's prepared nurses. And before sending nurses for master's education, they have to have a clear communication with these nurses about their role after they complete their master education and how their role will meet the organizational needs. Policymakers are advised to use the finding of this study to evaluate how the current utilization of master's prepared Omani nurses aligns with the national strategic plan and to design strategies to optimize the utilization of the current and future master's prepared Omani nurses, including setting policy to legitimize their extended role. And for education, educators are advised to work collaboratively with policymakers to identify the educational needs for future master's prepared nurses and to design curriculum and nursing programs that fit with the current service needs in Oman. For research, we identify multiple roles for master's prepared nurses, and I think future research could focus on exploring each of these roles in depth and evaluate how the competencies and characteristics of advanced practice nursing role are evident on those roles. In conclusion, master's prepared Omani nurses are valuable healthy human resources and have the potential to strengthen and empower the nursing workforce when their advanced knowledge and the skills are well utilized. So thank you very much. I'll be happy to answer any question you have.
Thank you, Salma. That was amazing. Is there anyone who has a question for Salma? No, we're just a couple of minutes over one, but if there is anyone who had any questions. I think, Salma, it's so striking how much work that you've done and how valuable this information will be. And I think one of the elements that really struck me was the need for, and perhaps you're working with like sort of nursing legislation to come up with protected titles, minimum competencies and roles of each of the different groups. So because that, I think, would allow more autonomous practice of a professional, the profession guiding the profession, and a better ability to sort of have equity and similarities across all the different sites that are using these groups.
Right, yeah. And as you said, I like the protected title because the titles are not protected, and even nurses, those who prescribe medications, there is no law in Oman allowing nurses to prescribe medications. So if these nurses, like if anything happened, these nurses will not be protected.
Mm-hmm. Yeah, is there a nursing college or a legislative group in Oman for the nursing profession?
No, actually we don't have. And I think this is the point. We don't have a regulatory body in Oman, like Ministry of Health. They control the hospitals under the ministry, and then like the university hospital, they have their own rules and regulation. This is why the clinical nurse specialist as a title exists only in the university hospital. It's not in the Ministry of Health. So Ministry of Health did not recognize the clinical nurse specialist as a title, but it is in the university hospital, which will affect the legitimacy and the feasibility of this role in Oman in general.
Yeah, and likely the best next step to try to work on a nursing college and a legislative group. So thank you, Salma. It's just amazing work, and thank you, Jessica, for today, and for everyone who joined.
Yeah,
take good care.
Thank you.
Thanks so much.